Len Calabrese, and I'm coming at you again to give you highlights from day 3. Today's highlights, I'm going to show you some clinical outcomes, some quality of life management in RA, and a number of abstracts on PSA. I'm going to open with a report on a study by Pombo Suarez and their colleagues who investigated the efficacy of JAK inhibitors in patients who fail to respond to their first JAK inhibitor treatment, and compared this to switching to other biologic DMARDs. So switching JAKs is a new area. We don't have a lot of data on it. I thought this was particularly interesting. This nested cohort study within an international collaboration of RA registries compared effectiveness of cycling JAK inhibitors versus switching to biologic DMARDs in 708 patients. So this is a real life experience. This is not a randomized trial looking at, outcomes here. So what that was found was that patients cycling JAK inhibitors were older and had longer disease duration and received more biologic DMARDs and had longer exposure to their first JAK-I than switchers to biologic DMARDs. So the JAK switchers, had more serious disease. And older population, again, a cautionary note today versus when these data were mined. Monotherapy was more prevalent and discontinuation of the first JAK inhibitor was more common for safety rather than efficacy. Another cautionary note. Cycling and switching strategies showed similar drug survival rates after 2 years of follow-up. So, I think a fair summary is that after failing the first JAK inhibitor, cycling to another JAK inhibitor versus switching to a biologic DMARD appears to have similar effectiveness despite a more difficult to treat patient profile for patients that are recycling to this. I think in view of recent safety data, I think we'll have to critically appraise this and look at a more granular fashion at this population. Staying with the theme of clinical outcomes in RA, Movahed and colleagues presented a poster featuring real-world physician and patient-reported outcomes when they compared the efficacy of 6 months of treatment with tofacitinib or a TNF inhibitor in RA patients. So they used real-world data from OBRI registry. 419 patients were initiating treatment between June of 2014 and December of 2019. Patients were required to have outcomes data available at treatment initiation and at least 6 months of follow-up. So what were the differences here? Well, the TNF group was less likely to have had a prior biologic DMARD, no surprise to us, 21% compared to tofacitinib, who were experienced 2/3 of the time, 67.9%. The rate of CDAI, low disease or remission at 6 months, were 33% and 26% in the TNF and TOFA group respectively. Again, different groups, different intensity. GLMM, as we say, showed no significant differences in CDAI, low disease activity, remission, RADI, HAQ-DI, sleep problems, anxiety, depression, a whole slew of quality of life measures in the 2 treatment groups. So, what do we say? Using the sophisticated, statistical model of looking at all of these quality of life measures, that the reported effectiveness were similar in the TNF and tofacitinib groups 6 months after treatment initiation in patients with RA. So let's move on to PSA. I want to highlight 4 interesting posters. Daniel Alataha and colleagues conducted a post-hoc analysis of pooled data from the phase 3 SELECT PSA 1 and 2 studies and the investigated baseline data and early responses for potential predictors of low or minimal disease activity at week 56, in PSA on upadacitinib. So again, post-hoc analysis, comparing baseline data to who achieve, very good responses. 640 patients with prior intolerance, experience to one or more biologics or DMARDs. Key results evaluated separately: younger age, male sex, geographic origin, lower weight, lower BMI, presence of dactylitis and enthesitis, and lower scores on patient pain, global activity, total joint count, and HAQ-DI were significant predictors for achieving MDA, DAPSA, low disease activity at week 56. Interesting to me, just reflecting on dactylitis and enthesitis kind of surprised me. Predictors for achieving sustained MDA and sustained LDA were similar to those that I've just discussed. So in PSA patients receiving upadacitinib, baseline characteristics and early responses strongly predicted achievement of MDA or DAPSA week 56. So maybe this is useful information as we make our drug selections. Another post-hoc study of the two select PSA studies examined the impact of upadacitinib on enthesitis in psoriatic patients. This is really important. I'm so impressed with enthesitis as actually being the source of major concern in my PSA patients more often than I had thought in years past when we didn't focus on this and measure it. So they used two enthesitis scoring systems, LEADS and SPARC, and compared UPA and placebo arms and analyzed these data at week 56. They looked for resolution with scores of 0 on both of these measurement tools. And what they found was a significantly greater improvement in the LEADS and SPARC scores was observed with UPA over placebo. No surprise. A higher proportion of UPA patients achieved complete resolution of enthesitis. It's a very potent drug in this area. Resolution was sustained or increased to 56 weeks, particularly with continuous UPA. And I think that that's a very important observation and when we counsel patients. And improvement was seen across enthesial sites with a high rate of maintenance of an enthesetic-free state after resolution. So 15 milligrams of upadacitinib is rapid and leads to comprehensive impact on improvement and resolution of enthesitis. Ian McInnes and his team reported long-term safety and efficacy of UPA and presented the results at 56 weeks from the SELECT-1 study. The efficacy of upadacitinib was compared to adalimumab and placebo throughout, and a number of outcomes were considered. These included achievement of minimal disease activity, resolution of enthesitis and dactylitis, and assessment of the psoriatic area and the skin severity, and achievement of certain ACR metrics. So a very robust study. 1,700 patients in that study received upadacitinib and adalimumab for 56 weeks or placebo for 24 weeks, and they were switched to upadacitinib. So most of us are familiar with these data, but when we look at it in this fashion, the proportion of patients receiving, achieving all of these metrics, ACR 20, 50, 70, MDA, PASI 70, 90, and 100, resolution of the enthesitis scores and dactylitis were maintained or further improved for week 24 to 56. When we treat patients, it's not just 24 weeks, it's over the long haul. So this is very important. And this was a very rigorous type of analysis. The improvements were similar to those who first were randomized to upadacitinib. And then through week 56, SAEs, treatment of emergent adverse events, including serious infections, were similar between upadacitinib 15 and adalimumab, but we're higher in the 30 milligram dose, which in the United States is not used. Upadacitinib 15 and 30 showed long-term efficacy in patients with psoriatic arthritis. So we're learning a lot more about this. So the final postdoc study in this selection was Quirera and their colleagues who focused on joint-specific response patterns in 422 patients with psoriatic arthritis treated with tofacitinib and adalimumab. And this is a really interesting study. And I haven't seen very many studies that have used this technique. They looked at paired joint pathology scores from the Opal-Broden study. And response patterns were compared to placebo to examine the efficacy of these two therapeutic regimens. This analysis, which you really need to see the figure to get the full breadth of this, and if you're interested, you can go back to the abstract, looks at joint inflammation throughout the body, kind of head to toe, where there is paired data. So if you have wrists, you want to know whether it's paired on each side, knees, toes, etc. So it creates kind of a, almost looks like a violin plot, but it's not a violin plot. So at 3 months, improvement was greater in joints below the knee with placebo. I have to think about that. Is it this unique form of analysis? It was, you know, the data are the data. At month 12, there was greater reductions in PJPs with tofacitinib or adalimumab, both in the wrists, radial MCPs, hand PIPs versus other joints. And at month 12, greater reduction in PJPs were observed with adalimumab versus tofacitinib in hand DIPs and PIPs, and feet with tofacitinib versus adalimumab. So there's no consistent joint response patterns observed with these drugs. And at 3-month delay in advanced therapy may result in radiographic progression in the feet. I have to think long and hard whether this is a useful analysis to me. I'd love to hear from any of you who look at this that have deeper insights into this, if you have any other differences. So 3 abstracts that stood out today focused on measurements and management of RA patients and quality of life. And I'll bring this home with looking at these. We'll start by looking at one of my favorite subjects, fatigue in RA patients, where Fattrell and colleagues examined the effects of baricitinib on fatigue in the BEAM and Beacon studies in that development program, and attempted to look at the direct relief of pain by baricitinib and answer the question, is this independent of disease activity? This seems to be a very hot question in therapeutic trials now. So we know the BEAM and the Beacon trials, and so the data were extracted from that. And so the first key result is that in the methotrexate incomplete responders, disease activity mediated effect accounted for 50 to 60% of fatigue improvement in Bara and ADA over placebo. So, you know, you're taking that group of patients, and then in those that got good response to disease activity metrics, that could account for 50 to 60% of fatigue improvement. The total direct and mediation effect of fatigue relief increased with baricitinib, increased from week 12 to 24. There is a change over time. And in biologically experienced patients who entered this study, 20 to 30% of the effects of BARA, and they use the FACIT fatigue, by the way, were independent of disease activity. And they looked, you know, with rigor whether these patients had met the meaningful change of 4 units in FACIT fatigue. So in conclusion, in methotrexate and biologically experienced patients, baricitinib had effects on fatigue independent of disease activity. The direct fatigue relief effects of baricitinib over placebo were significant at week 16. We're starting to see this in numerous other drugs. This is my kind of additional editorial comment, that it's not just patients who go on biologics or JAK inhibitors and have fatigue improved that can be accounted for on the basis of lowering inflammation, joint scores, skin scores. There's something else there. Is that placebo effect, a potent biologic phenomena, or are there other pathways, perhaps cytokines inhibited by these drugs that are affecting CNS pathways and or sleep? Very exciting data, needs to be followed up on. Seba and colleagues analyzed swollen joint count and pain data derived from the 3 RA-Beam studies and assessing the relationship between pain and inflammation in this study, which included baricitinib in RA. So they took the results, patients who were on bara plus methotrexate, adalimumab plus methotrexate, and they looked at the people who had good responses, greater than 50% improvement in swollen joints, and those who did not at week 12 and 24. So you got responder, non-responders. So for patients who did not achieve 50% improvement in swollen joint count, those treated with baricitinib reported significantly greater improvements in pain than adalimumab. This difference was not observed consistently in the group achieving 50% swollen joint responses. The significant interaction test implies a differential effect of baricitinib on pain, not associated with improvement of inflammation. So we have another one. Fatigue and pain. What is the mechanism that is working outside of the direct effect on inflammation and targets in joints and skin? You know, there are cytokines that can be inhibited by JAK-STAT pathways, over 50 cytokines and chemokines, including things like GM-CSF, IL-6, which have direct nociceptive properties, perhaps contributing, just one hypothesis among many. Final highlight of the day, RealWorld colleagues looked at the challenges of managing persisting pain in RA. And there are many types of pain in RA, mechanical pain, inflammatory pain, neuritic pain. They discussed the differences in reported pain between responders and non-responders in the reference group and included an assessment of the impact on patients' mental health over 48-week studies. And we know that pain is a comorbidity for intercurrent mood. So I think that this is a really interesting study. So prospective non-interventional study in rheumatology centers. So looking at real-world data, 24 weeks, they looked at a reference, non-responders, and persisting pain, G1, G2, G3. And they found the proportion of these neuropathic pain subgroups was similar in G3 and G2, non-responders and persisting pain, 25% in each group. Between 24 and 48, subjects in G3, persisting pain, attaining this RAID pass metric, increased from 8 to 23%. And simultaneously, DAS-CRP decreased from 3 to 2.4, 2.9 respectively, small decrease. During this period of the study, the proportion of patients in G3, the persisting pain group, with moderate depressive symptoms or worse, hardly changed. So the role of intercurrent mood disorders. So neuropathic pain is a frequent underrated challenge in RA patients. I don't think we routinely appraise this in data. Our patients talk about dysesthesia, and we wonder in fibro patients, is that the pseudodysesthesia of fibromyalgia? But more recent data suggests that there's an increased incidence of small fiber neuropathy in that group. But in patients with that not responding to anti-inflammatory treatment should not be surprising. So it's a really fascinating study. It's complex. I urge you to go and review it in detail. So another busy day here. It's been interesting to see such a strong focus on quality of life, near and dear to my heart. If you haven't already, download our highlights brochure. It really has the big 30,000-foot view of what's going on here. You can watch the previous day highlights and catch up with any session you might have missed. Thanks again for joining me. I really enjoyed this roundup on day 3. And again, my good buddy, Professor Grace Wright, will join you tomorrow and take you through the highlights from day 4, the final day of ACR 2021. I hope you have followed us all on Twitter. I hope you're following me on Twitter, L Calabrese DO, easy to find. You can get information on what's going on at the CSF site. It's been a great pleasure. Thank you.